Hello, my name is Crystal Vandevoort, and today I'd like to talk to you about decreased milk supply with a hypoglycemic newborn, in part of the BCIT Breastfeeding Experience Theory course. First off, we'll start by introducing the situated decision-making framework. We will discuss the breastfeeding challenges of decreased milk supply with a hypoglycemic newborn. And then we will apply this framework to assist clinical decision-making and guide professional practice. The situated decision-making framework is comprised of 5 factors: knowledge, cues, judgments, decisions, evaluation of outcomes. The various phases that comprise the clinical decision-making process are not linear, but inform and may be informed by one another. Knowledge. Knowledge and the hypoglycemic newborn. Hypoglycemia in the newborn refers to insufficient blood glucose concentration with greater body demands in the first few days of birth. Glucose is required for energy and brain function. It is delivered during pregnancy through the placenta and through colostrum after birth. It is also stored in the infant's liver, heart, and skeletal muscles as glycogen during the last trimester of pregnancy. Infant risk factors: hyperinsulinemia, intrauterine malnutrition, whether the infant was small or large for their gestational age, asphyxia, infection, perinatal stresses such as cold stress or difficulty of delivery, if the infant was preterm, endocrine abnormalities, a delayed first feeding or infrequent feeding, and separation from the mother or lack of skin-to-skin contact. Maternal risk factors: diabetes, including gestational diabetes, poor diet, smoking, pregnancy-induced hypertension, certain medications the mother may be on, whether there was a difficult labor, and if the mother was given a glucose infusion during labor. Knowledge and decreased milk supply. Maternal risk factors: primary insufficiency, which is rare, has to do with insufficient growth and development of the breast. Polycystic ovarian syndrome, where a woman may have insufficient breast tissue or insufficient glandular tissue. Hormonal conditions that cannot be treated, such as Sheehan syndrome or polycystic ovarian syndrome. Issues that may be corrected, such as retained placenta, untreated low thyroid, or anemia. And physiologic challenges, such as inverted nipples or previous breast surgeries. It should also be noted that certain medications and smoking may also interact, decreasing hormones required for milk production. Secondary insufficiency: delayed or infrequent feeding, ineffective feeding, where insufficient milk removal or infant intake is taking place, separation or lack of skin-to-skin contact, or the introduction of supplements or pacifiers that limit time at the breast or challenge breastfeeding success. Infant risk factors: tongue tie, jaundice, illness, congenital conditions, if the infant was preterm or small for their gestational age. Cues. Cues of the hypoglycemic newborn, signs and symptoms: jitteriness, tremor, weak or high-pitched cry, lethargy, limpness, convulsions, cyanosis, apnea, tachypnea or irregular respirations, diaphoresis, hypothermia, a refusal to feed, tachycardia or bradycardia. It's important to ask, has mom or family noticed any of these signs or symptoms? Diagnostics: at-risk infants should have their blood glucose tested within 1 hour after birth, ideally 30 minutes after the first feed, and repeated in conjunction with feedings until blood glucose has been above 2.6 millimoles per liter and has been stable for 12 hours. Blood glucose concentration less than 2.6, the infant should repeat feed with another blood glucose test within 1 hour. Blood glucose consistently less than 2.6 after subsequent feedings should be considered for IV glucose management. Symptomatic newborns should be considered for immediate treatment. Cues and decreased milk supply. Signs the infant is not getting enough. The infant may appear asleep at the breast, unable to latch, struggling for hold, pulling on or off the breast, maybe playing with the nipple, cheeks dimpling, tongue thrusting, and the infant may appear frustrated, crying, and flailing. The mother may experience extremely painful nipples, or nipples that are tube-like in appearance and not rounded. It's important to ask, how does mom think the feeding is going? Is she having any difficulties? What has she assessed of the infant's behavior? Cues: decreased milk supply and the hypoglycemic newborn. Assess the feeding relationship. Has the mother-infant dyad been separated? Has breastfeeding been attempted early and often? Feeds should be every 1 to 3 hours and 8 or more episodes within 24 hours, including night feeds. Has the feed been effective? Is the infant swallowing audibly? Do they appear sated afterwards and relaxed? Has there been appropriate weight loss, wet diapers for their age, or bowel movements for their age? Has there been skin-to-skin contact? Judgment. What could be happening? Effective breastfeeding may not be occurring, thus impacting the infant's blood sugar and the mother's milk supply. Nursing priorities. Number 1, efficient monitoring and treatment of newborn hypoglycemia. Number 2, increase maternal milk supply. And number 3, ensure the infant has adequate intake of nutrients. Decisions. Decisions in the hypoglycemic newborn. Treatment plan. Feed the infant. If breastfeeding is ineffective, milk may be expressed and fed via cup, spoon, or syringe. Donor milk may also be provided this way if needed. Artificial substitutes are available if medically necessary. Ensure skin-to-skin contact to maintain blood sugar and reduce infant stress. Has blood glucose been below 2.6 with subsequent feeds? If so, further management and/or investigation is likely required. IV glucose in combination with breastfeeding is ideal. The Canadian Pediatric Society has put together an algorithm for the monitoring and treatment of newborns at risk for hypoglycemia. Decisions and decreased milk supply. Treatment plan. Move the milk. The 3 E's. Early and often, within 1 hour of birth, every 1 to 3 hours, 8 or more times in a 24-hour period, including night feeds. Breast stimulation via infant, hand expression, or pump, and massage and warm compresses, which are also recommended to aid the letdown process. Effective breastfeeding. Improve the latch and technique if required. And exclusive breastfeeding, unless supplementation is medically required. Avoid pacifiers or anything that could confuse the newborn and challenge breastfeeding until it is well established. And skin-to-skin contact, which produces oxytocin and promotes milk production. Evaluation of outcomes. Is the infant's blood sugar improving, and is it now stable? Is the infant appearing happy, active, and healthy? Has the maternal milk supply increased? Let's reevaluate. Is there now an effective feed? Is output suggestive of adequate intake? And is weight appropriate for age? Was the mother-infant relationship and the feeding experience supported and nurtured? And would referrals be appropriate at this point? In conclusion, decreased milk supply and the hypoglycemic newborn. These issues have been discussed utilizing the situated decision-making framework as a means to aid revolving clinical decision-making. Situated decision-making framework consists of 5 factors: knowledge, cues, judgment, decisions, and evaluation of outcomes. Knowledge and cues help form judgments of possible challenges. Nursing priorities are able to be determined and decisions to be made thereafter. All interventions require diligent reevaluation as a means of success. And the 3 E's. Early and often, effective, and exclusive breastfeeding help to prevent and treat many breastfeeding challenges, including decreased milk supply and hypoglycemia in the newborn. Thank you.